After sonographic assessment for varicose veins, this session I want to extract the other part of the newly released venous guideline, which identified as the classification and grading clinical severity in chronic venous disease. Finally, this part will be ended with some examples in different clinical scenarios. Hi, this is Dr. Alireza Serati, interventional cardiologist and venous disease investigator. This part is not only beneficial for radiologists who are interested in vein disorders, but also is important for phlebologists and surgeons who want to intervene pathologies arise in venous territories. The first widely adopted venous classification developed in 1978. In 1993, during the 5th annual meeting of American Venous Forum, John Porter suggested a classification for venous disease. It was updated in 1996 and revised in 2004. In 2017, the American Venous Forum created a CEAP task force team to analyze the current classification system and make proper revisions. In 2020, this task force team added some changes with some revisions and published it in the Journal of Surgery as the revised CEAP classification. This classification is adopted worldwide for an understandable description of chronic venous diagnosis between all healthcare professionals. The name CEAP classification stands for C as clinical, E as etiological, A as anatomical, and P as pathophysiological. In this classification, S stands for symptomatic, which means symptoms of varicose veins that include pain, burning, cramping, feeling of limb heaviness, or swelling, especially after long standing. Restless leg or itching are also included. The most important of these symptoms have been identified as hasty symptoms and include heaviness in the leg, achiness, swelling, throbbing, and itching. Regarding C as the clinical marker, 7 clinical categories are recognized as below. C0, no visible or palpable signs of venous disease. C1, which is divided into 2 categories, telangiectasias, which are subdermal spider veins less than 1 millimeter in size, or reticular veins, which are subdermal veins between 1 to 3 millimeters in diameter. C2, varicose veins with a diameter of 3 millimeters or more. C3 defines as the presence of edema. C4 defines changes in skin and subcutaneous tissue secondary to chronic venous disease, and it is divided into C4A, which is pigmentation or eczema, C4B, lipodermosclerosis or atrophic blanch, and C4C as chronophlebectasia. Note that C4C is pattern of numerous small intradermal reticular and telangiectatic veins presented on the medial or lateral aspect of the ankle and foot and is very different with C1. They are early signs of advanced venous disease. Note that C4A, B, and C all have the same weight in severity of the venous disease. All C4 stages may predict the development of leg ulcer. C5 stands for healed venous ulcer, and finally C6 is for active venous ulcer. In case of recurrence, a small r is adding at the end. Regarding E, the etiological classification divided into C for congenital cause, P for primary cause, S for secondary, which is divided into intravenous or extravenous, and N stands for no identified venous cause. Note that heart failure and May-Turner syndrome are extravenous cause of variceal veins. Regarding A, anatomical classification divided into 4 categories. S for superficial vein, D for deep veins, P for perforating veins, and N for non-identified venous locations. At the end, pathophysiologic classifications divided into 4 categories. R stands for reflux, O for obstruction, R, O for reflux and obstruction, and finally N for no identified venous pathophysiology. Chronic venous disease is identified as CEAP class C2 to C6, and chronic venous insufficiency includes limbs with CEAP class C3 to C6. CEAP is not a static classification, and venous disease can be reclassified at any time. Classification starts with the patient's initial visit, but can be better defined after further investigation. Sometimes the final classifications may not be complete until after surgery and histopathophysiologic assessment. CEAP is a descriptive and not quantitative severity scale. Another terminology is Venous Clinical Severity Score, revised in 2010, which accepted for grading of clinical severity and for assessment in post-treatment outcomes. Venous Clinical Severity Score, or VCSS, is responsive to changes over time and is suitable for responses to treatment. It has 9 components of pain, varicose veins, edema, pigmentation, inflammation, induration, presence and size of ulcer, and use of compression therapy, and each component scaled of 0 to 3. Venous Clinical Severity Score, together with the CEAP classification, has been widely adopted in many international venous guidelines. Guidelines recommend the use of the 2020 updated CEAP classification system for chronic venous disorders. The basic CEAP classification can be used for clinical practice, and the full CEAP classification system should be used for clinical research. They recommend the use of the revised Venous Clinical Severity Score for patients with chronic venous disorders, for grading of clinical severity and for assessment of post-treatment outcomes. Clinically, VCSS appears to have a better ability to discriminate patients at more severe CEAP classifications. Let's go through some common examples for CEAP classification. This is a patient with leg ulcer and no history for DVT, but great soft venous vein reflux below the knee is noted. The complete classification would be, and the basic form is, this is another patient, again with leg ulcer and history of DVT and superficial femoral vein obstruction along with GSV and a cuff perforating reflux. The complete classification would be, note that for venous nomination, ordinary superficial is first, then deep, and finally is perforator. For this patient, the basic form would be, the other patient has ulcer with isolated cuff perforator reflux. Complete definition would be, and basic form is, for VCSS score, referring you to a calculator, which the link is coming below. In the next talk, I will discuss about the first part of treatment for chronic venous disease, which is compression therapy, and I digest it properly for you. See you soon.